it's much more difficult to have an interaction with somebody who has a lot of experience, because everybody has their own ideas. And please, do not change anything. Do not listen to me if you don't have any problem. If you don't have any problem, don't change the techniques, don't change anything. From another experienced guy like me, you can get maybe 10%. The one who has no experience, if they follow the protocol, that is not my protocol. It's the protocol of a group that is done over and over and over, with the same manner, with the same type of procedure, and it works not only in my hands, but in the hands of many, many professionals. The modern trend is to be minimally invasive. That means avoiding bone graft. That's why I introduced the all-on-4 concept that you ask. Whether without the clinical indication is just a marketing tool. What do I mean for that? I mean that you, being physician of the mouth, you should always have the possibility to reply to the first question. Why, doctor, are you doing this procedure? Which is the clinical indication. And you know that, unfortunately for our patient, worldwide, the industry and the professionals are trying to standardize the procedure. That means they are extracting all the teeth and placing 4 tilted implants. Why? It's a money-oriented implantology because it's a much more, let's say, profitable. So minimally invasive without the right clinical indication is just a money-oriented implantology. And since you are here on Monday morning, travel a long way, and I have a lot of respect for your time away from the practice, I know that everybody that comes here, that travels a long way, they are ethically oriented, and they are doing the procedure that you will do on your loved ones. Minimally invasive means reduce the post-op discomfort for the patient, that is very important, and reduce the possibility of intra and post-op complication. That's very, very important. Why we have many different treatment plans when we see a patient? Because the poor patient is in the center of this slide, but he receives the treatment plan due to different factors, and the different factors that you see are listed influence our clinical decision. All around the world, 90+% of dentistry is private. Being private, there is even a financial implication to your treatment plan. So the cost that the patient can sustain are very important. So you have to modify maybe the treatment plan and find a good compromise. But improving the efficiency of your procedure, doing multiple procedure at the same time. With the introduction of the digital dentistry, we were able to lower the fee, like in every other sector of medicine. I'm working in a big orthopedic hospital. The fee of the orthopedic surgeons are 100% lower compared to 10 years ago. 10 years ago, the fee was the double the price that they charge today. The economy has changed, so if you want to keep up with the changing situation, you have even to work on that. And with the introduction of digital dentistry, with the introduction of the concept that we are teaching worldwide, one surgery, that means a team with anesthesiologist, a team that knows how to do sedation. 70% of our sedation are done internally by our team. So we train dentists. We train dentists on how to do sedation. And we have a protocol that has been approved by the Ministry of Health here in Italy. And even dentists, they can do sedation. By doing sedation, you can do multiple procedures at the same time. The second big important factor to change the treatment plan that nobody of us is promoting something that he cannot master with his hands. Nobody is telling to the patient, do this if you are not able to do the procedure or you don't have experience. You will try to convince the patient to do something else because you don't want to do a procedure that you are not able to master. So, and what about a little on evidence-based dentistry? Evidence-based dentistry is not only what it's written in scientific papers, but is a combination between your skill, your expertise, your experience, the patient preferences, and the equipment and the tool that you have available. I've seen that some of you are doing a lot of implants, 500 implants per year. If you take that professional and you put him in the middle of Africa, in a hospital that has no organization or leader organization, and the nurses are not trained, most probably he will drop the number of implants and he will not be able to deliver the same care. So evidence-based dentistry means that you have to take into consideration even the environment in which you are working. In the literature, you will not find all the questions that might cross your mind if you don't know the answer to that questions will be found in the basic science. That could be physiology and anatomy. First of all, if you want to diminish the number of intra-op and post-op complications, you should start from an healthy sinus. What means to have an healthy sinus? Means that the ostium should be open. This is the ostium that drains all the mucus with an anti-gravitational movement towards the ostium. Without knowing, everybody of us is swallowing 1.5 liter of mucus every day. And if you have an efficient mucociliary transport, the sinuses are considered sterile. When you start lifting the sinus, even if you do not make any kind of perforation, the sinus will have inside the sinus a minor bleeding, because you detach the mucosa from the base, the bony base, and you can start having some little stream of blood that are coming towards the ostium. That's why the patient is normal, that can tell to the doctor, I have a minor bleeding from the nose, even without any kind of perforation. The natural ostium is this one. The natural ostium is 6 by 10 mesiodistally, from 2 to 4 in apicocoronal direction. It drains in the middle turbinate and is protected by this, that it's called uncinate process. 30% of your patients, they have this accessory ostium that is another opening, and this accessory ostium is a non-functional ostium, does not drain any mucus. It's very important, every single word that I do. Why? That I say. Why? Because sometimes even ENTs, ear, nose, and throat specialists, are making some kind of mistake opening the accessory ostium through the nose to treat sinusitis, and the patient will not recover. So to have you understand the sinus mucosa, there are 3 layers: the periosteum layer, the middle layer, in which you have the cells that are producing the mucus. On top you have cilia that are beating in an aqueous solution. On top of the aqueous solution there is this sticky substance called mucus. Why it's important to understand this? Because if you don't know physiology, lack of knowledge, you cannot understand why, in case of perforation, the membrane will continuously move. Doctors, they think when you have a perforation, the membrane will not move. When you have a perforation, the membrane will move anyhow. Why? Because there is the bridging phenomenon. That means that the cilia are bridging little gaps. Only if you have a big perforation, the membrane will not move. Small perforation, the membrane will always move. That's clinically very important. Why? Because doctors, they swear to God that Tiziano, the membrane was moving, and I didn't make any perforation. So the clinical implication of knowing the anatomy of the sinus membrane is, due to the composition and how you have 3 different layers. These 3 different layers dictates the movement of the membrane with a small perforation. Conclusion: small perforation due to the anatomy of the sinus membrane will not interfere with the movement of the membrane. What you see on cone beams is not really the reality sometimes, because in reality the membranes are a little bit thicker than what you see on the CAT scan. This is very important to understand that like in periodontology, you have different type of phenotype, different type of flaps. We have here a classification mainly created by Vercellotti, the inventor of the piezo surgery, that tells you that usually thick membranes are the one who are white and no transparency. The medium thickness membrane, they are dark in color with mild transparency. And the very thin membranes are colorless and transparent. Is it important to understand that, it's very important to understand that, for example, you can suture the first type of membrane with resorbable catgut suture, but you cannot suture, for example, thin membranes when you have a perforation. So the ones who are telling you, I can suture every type of perforation, are lecturers with little experience. They try once and it succeeded, they succeeded, but it's almost impossible, even for a super experienced one, to suture the thin membranes. So, think that the range in microns of the thickness of the membrane, they can range from 50 microns to 500 microns, so 10 times more between the thick membrane and the thin membrane. So very thin membrane is like when you do perio in a thin biotype in the lower incisor, for example. When you want to do a coronally advanced flap in thin biotype in the lower incisor, you have a very thin, superficial, split thickness flap, and you are in the range of 100 microns, 150, 200 microns. And it's very difficult to suture. If you want to have somebody that can help you in treating post-op complication, you should find in your country somebody who is knowledgeable in functional endoscopic sinus surgery. That is a surgery done through the nose to correct and to treat this kind of problem that we can create with our surgery. We publish an anamnesis in this chapter in the Holly Jensen book, and we ask specific questions to the patient. And if we find that there are some positivity to these questions, along with the interpretation of the CBCT, we might think to refer the patient. And then I will show you all the clinical scenario when it's better to refer to a knowledgeable ENT, because not every ENT is knowledgeable on what we do. An ENT can even help you during the pre-op phase to treat the patient if you have some pathology inside the sinus. A knowledgeable ENT can help you. And on top of that, it's very important to understand that no one ENT is knowledgeable in dentistry. So if you have an odontogenic sinusitis, you should refer the patient to an ENT, but you should be able to understand that some pathology inside the sinus are created by periodontal lesion or endodontic lesions. The clinical symptoms and signs of infections are the following, in which you have graft material in the ostium, for example, after a sinus lift, with a list of symptoms and signs, and always think that odontogenic sinusitis are mainly unilateral. So when you see a patient with a sinus that is not healthy only on one side, 95% of the time is odontogenic origin, perio, endo, or implants. There is a sign that is frequently pathognomonic of odontogenic sinusitis, that is a foul smell. When the patient tells you that he has a bitter taste of his smell, a bad odor, that is most probably odontogenic sinusitis. So when it is unilateral, bad smell, bad taste, think about odontogenic sinusitis. And the etiology of odontogenic sinusitis is the one listed here. And so the etiology could be endodontic, periodontal, oroantral communication, or oroantral fistula, which is the difference between communication and fistula. Fistula has the epithelium, oroantral communication, no epithelium, small communication if the sinus is healthy, and I will show you, in 4 to 6 weeks, they can self-close. They close spontaneously. Fistula will never close spontaneously. Foreign body in the sinus, root and sinus lift with a graft dispersion inside the sinus, they can create odontogenic sinusitis. So it's important to refer the patient to an ENT. Why? Because we demonstrated in this paper that when you start from an healthy situation, you decrease enormously the intra-op and post-op complication. So we ended up writing in this paper that is now published. You can find in Perio 2000. Send me an email, I can provide you all the information that we have here. In this publication that was done between us and the group from Michigan, we classified when to refer the patient to an ENT specialist who is knowledgeable of sinus surgery. So if you start from an healthy sinus, obviously don't send the patient. If you have a sinus that has a mild thickening but an open ostium, don't send the patient. You don't need to send the patient. So first of all, always acquire the CAT scan up to the ostium. We want to see the ostium. So the field of view should be at least up to the orbit. Now, with the new CBCT, larger field and you can low dose, we are acquiring up to the frontal sinuses. Why? Because if we have to refer the patient to an ENT, he can look at the 5 sinuses. So if you have the possibility to refer the patient to a knowledgeable ENT, it's better to acquire this field up to the nasal, to the frontal sinuses, so they can see everything. Otherwise, you have to, when you send the patient to an ENT with this up to the orbit, they request to the poor patient an additional CBCT. Clinical message: don't look at the thickening of the membrane. The issue is, look if the ostium is open or not. Do not acquire a CAT scan in the lower third, but at least at the orbit, ideally at the frontal sinus. Do not send a patient to an ENT for Cuncta bullosa. Cuncta bullosa, it's a middle turbinate with some hair inside the middle turbinate. Cuncta bullosa is not an indication for, you don't have to send a patient with a Cuncta bullosa to an ENT if you have a clear sinus. There is no way, because if the ENT is not super honest, he will operate the patient and you will delay your dental procedure, implant procedure. So you see this anatomical variation. Don't send the patient. It's written in the ENT guidelines all over the world, but some ENTs, they say to you, let's prevent a possible future closure of the ostium. Remove a Cuncta bullosa. It's not ethical to do that. Septal deviation, again, is not an indication for sending an ENT for sinus lift, Send to an ENT if the patient is not breathing well. He cannot breathe. You want to improve the breathing status of the patient because he cannot breathe well. Send the patient for an ENT consultation. But if the patient is breathing anyway with a septal deviation, keep it. Don't send the patient and do the sinus lift. Mucosal thickening due to periapical lesions. Remove the tooth, remove the perio lesion, everything will heal. The only thing, check if there is bone over here. If there is bone, fine. If there is no more bone, think that the lesion is attached to the sinus membrane. Don't remove the lesion. Leave a little bit of lesion attached to the periosteum of the Schneiderian membrane in order not to create a communication. Mucosal cysts that do not interfere with the sinus lift. I have to lift the sinus and I have a mucosal cyst in the posterior wall, in the mesial wall, the floor of the orbit, on the palatal wall. Lift. According to the literature, 15–30% of your patients have a mucosal cyst that should not be removed if they are not in the way of the sinus lift. Why we remove the cyst in the way of the sinus lift? For one reason, because it's very difficult to lift the membrane if you have a mucosal cyst. Because mucosal cyst, it's more difficult to lift the membrane because maybe you have 3–5 cc of liquid that prevents you from lifting the sinus. Always think that it's a normal finding to find a submucosal retention cyst in the sinus. Chronic rhinosinusitis with nasal polyps is not an indication for sinus lift. You should send the patient to an ENT. Usually are bilateral. There is no foul smell, no foul taste, and chronic rhinosinusitis is a different issue, so you should send the patient. Always remember that a CBCT, you are not able to differentiate liquid from solid. When you send a patient to an ENT, they will ask for magnetic resonance imaging in order to understand what is liquid and what is solid. If you have a lot of experience, you might presume that this could be a benign tumor, like an inverted papilloma with local malignancy. Or you can even have squamous carcinoma. Always have in mind that you should send to an ENT to do a magnetic resonance imaging when you have bone erosions that are not due to dental infection. If you are 100% sure that a bone erosion is due to endo and perio, don't send the patient. But if you have any doubt, a bone erosion can be even a cancer. This shows you the comparison between CBCT and magnetic resonance to give you the idea that it is impossible to differentiate the solid and liquid. This is a true story. This is a patient that came to our hospital to ask for a second opinion because the doctors was not paying attention to this lesion. Always remember that there is a guidelines for the World Health Organization. When you see a mucosal lesion that does not heal in 2 weeks, it's better to refer. If you have a little bit of experience, not even without asking to the patient, for how long you had this lesion, and she says, 6 months, don't wait 2 more weeks, send the patient immediately. But even without asking anything to the patient, when you see a red lesion with a lot of capillaries and not a white lesion, it's better to refer immediately to the patient because you know exactly that red lesions most of the time are something else that won't heal in 2 weeks. So it was not the indication for sinus leak because this is a squamous carcinoma coming from the minor glands, salivary glands of the palate. So this is a cancer, so I refer the patient to our maxillofacial department. They do a double afibula reconstruction, and then later on we can place the implants. In private practice, we do not see so many cancer, and we forget that sometimes there are even this type of pathologies. Mucosal thickening and the ostium is closed, we should refer the patient to an ENT. So it's not the issue, the thickening of the mucosa, is the opening of the sinus. And you should send the patient to an ENT. Fungus ball or mycotic sinusitis are mainly created by endodontists when they push some endocement inside the sinus. And then you have fungi that can create aspergillosis, mycotic sinusitis. Usually are due to an infected endotooth or due to the cement that went inside the sinus. When you have this kind of problem, you should refer to the patient. Implants inside the sinus should be removed because they travel and they can go even in other sinuses, and I will show you during the complication. All the sinuses are interconnected. An implant inside the maxillary sinus can travel up to the sphenoidal sinus due to an infection because all the sinuses are interconnected. The ones that are not creating problems are the implants that are submucosally placed. You have the mucosa, you have the implant, and you have the bone, and the implants in between the two layers. These are the ones that stay there forever. But since we don't know, unless we do an endoscopic view, which is the situation, it's better to remove all the implants inside the sinus. Why? because the ENTs can insert an endoscope not through the natural ostium. There are prototypes because the natural ostium is very small, from stores with very, very small 1 millimeter endoscope, but still the images are not as good as when they have a larger endoscope that can be inserted between the accessory ostium, that is much larger. So our guidelines are remove the implants inside the sinus. Remove the wisdom teeth that sometimes maxillofacial surgeon or dentists are trying to remove the wisdom tooth. They go inside the sinus, the suture, and they don't say anything to the patient. And then you can have odontogenic sinusitis. When you have this scenario that you cannot really define what is bone and where is the thickening of the membrane, and the bone is like this, that is foamy, think that there is a long-lasting chronic sinusitis that has altered the bone of the sinus as well, with calcifications. These are long-lasting sinus problems. You can refer the patient, but it's very difficult to regain completely the health of the sinus. If you start from an healthy sinus and you push an implant inside the sinus and you get a kind of odontogenic sinusitis, when you remove the implant, not through the nose, but through the intraoral approach, the sinusitis will be completely solved. So, if you are the one who pushes the implant inside the sinus, but you know that the sinus opening is patent, the sinus ostium is open, don't send the patient. Remove the implant from an intraoral approach. Why? Because if you send the patient to an ENT, 99% of the time, he will remove the implant from the nose. Why? Because it is his approach. He knows how to remove the implant from an intranasal approach, but not from the intraoral approach. Every time you send the patient to an ENT to remove the implant, remember these guidelines. We were born with the uncinate process that allows us not to get water inside the sinus when we jump into the lake, when you go to a swimming pool, or when you go to the seaside. So it's better to preserve the integrity of the anatomy of the nose. But you have to be 100% sure that you started from an healthy sinus. And you have to do an antrostomy that is right on top of the, like in this case, of an implant that is stuck in the ostium. If you go through the antrostomy where you did the sinus lift, it could be a big problem because you are not able to go up higher. So look at this. Healthy sinus, you create the problem, you solve the problem without referring the patient to an ENT. Or if you are not able to remove the implant from an ENT, ask a maxillofacial surgeon, your friend, to remove the implant from an intraoral approach, because it's better for the patient. Always remember that implants, they travel inside the sinus, so you have to remove the implants with a CBCT done before the removal. If you ask for a CBCT CAT scan and you remove the implant 3 weeks down the road, look at this implant. This implant is here, tip of the implant, collar of the implant. And it is in this region. Then it moves to the posterior. And then this is the tip, and this is the collar of the implant. So they change time, they change position in time. So it's better to remove the implant the same day you do a CBCT. Don't do the mistake of removing the implant. Look for the... Why? Because the sinuses, they can range from 10 cc, small sinuses, to 30 cc. 30 cc of volume, it's a big sinus. And with our antrostomy is up higher near the ostium on the posterior part, you will not be able to remove the implant unless you make a super large osteotomy. You have to open a small antrostomy right on top of the implant that you have to remove. Like in this case, that it was, the antrostomy was a small antrostomy right where the implant is. This is another case. You see the implant. This is the implant. They change in time. And you have to open the antrostomy where the implant is. I do a CAT scan, I remove the implant. And if you started from an healthy sinus, I solve the problem in the office. Or these are cases that I even do for many of my course participants or other doctors that they know. If they start from an healthy sinus and there is an implant inside the sinus, don't send the patient. Why? Because the ENT, they do this type of intervention through the nose under general anesthesia. You have to hospitalize the patient at least one day, or early in the morning they dismiss the patient. But for the poor patient, it's something that is not really a piece of cake. They have to go and to have a general anesthesia. Here they come, they do a small antrostomy, and everything is done. So, it's an implant in the sinus. It's a matter of having a friend that does not speak badly about you. Friends that are solving the problem without blaming the poor dentist. Because if you do not work, no complication. If you work, some complication. You should help your colleagues and not blame your colleagues. That's the main focus. So it's important to solve the problem for the sake of the patient without sending the patient to hospitals and remove the implants from an intraoral approach. That is very, very easy. You have seen in few months everything will heal. Mario Mantovani is a good friend of mine. He's the one who wrote the chapter of ENT implication in sinus lift on our book that is 25 years old. My first sinus lift was in 89. And he developed an antral retriever. Why? Because he is one of the ENTs that has multiple specialty. He has a specialty in ENT, maxillofacial surgery, ophthalmology, and plastic surgery. So he has a 4 specialty. Having 4 specialty, he has a very open mind. He has been working with dentists and implantology forever, so he knows exactly that it's better to remove implant inside the sinus if you started from an healthy sinus from an intraoral approach. He is very talented in using this. It's called antral retrieval. It doesn't make any kind of flap, no flaps, through the cuspid fossa. He is able to insert endoscope, a special instrument, so he removes the implant utilizing this. I'm not so skilled in using these instruments. For me, it's better to do a little flap. It's more predictable in my hands and in your hands to open a little antrostomy and to remove the implants. Bone fenestrations. When you see a bone fenestration and soft tissue closure, always remember that in that specific spot of bone fenestration, there is the attachment of the periosteum of the flap towards the periosteum of the Schneiderian membrane. And in this case, you should do a split thickness flap, and we made a publication showing you when you reach the bone fenestration, your blade should cut more towards the flap. Like in this case, you have the attachment of the periosteum of the sinus mucosa to the periosteum of the flap. It's very difficult to find a plane of dissection between the two periosteum. So if you want to stay on the safe side, your blade leaves the periosteum of the flap attached to the periosteum of the sinus membrane. Because if you insist, the weak part is the sinus membrane, and you will create a big perforation. So it's a matter of changing your technique and do a split thickness flap in order to not to create a big perforation. If you reflect inside the sinus a little bit of connective tissue of the flap, no problem. Maybe the last part of your graft will be embedded in connective tissue. Is it clinically relevant? 0. But you avoid a major problem that is a big perforation.